test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1. Questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi Hannah, nice to meet you.
Hi.
So I understand that you were referred to me by your GP because you've been experiencing some anxiety difficulties.
Yeah. I guess it kind of started like 5-6 years ago.
Okay.
It escalated a bit. I've just recently moved out from living with my parents, so it's made it a bit worse, I think.
Okay, is this the first time that you've left home?
Yeah, it's the first time actually, yeah. I was going to a few years ago. I just thought it would be easier to stay at home, so.
Okay, so it's been quite a big step and a big change, and it sounds like that was what led you to go to your GP.
Yeah.
So how has that changed things for you?
Do you know, it's kind of, I haven't really told anyone, so, I mean, it's made it like better in the sense that I feel hopefully this is it, like it'll help, but I don't know, I don't like thinking that I've had to do this. I never thought I'd be the kind of person who'd have to actually go and get help, if that makes sense.
Okay, so how do you feel about being here today?
A bit scared, I don't know, hopefully it will help.
Okay, so you've been feeling a little bit anxious about today?
Yeah.
Okay, so I guess just going back to why you went to the GP and how you've ended up kind of coming here today. So it sounds like you've been experiencing anxiety for quite a few years, but just recently you moved out of home for the first time, and that was what kind of led you to go to the GP. So how did that change things? How were things after you moved out?
I thought that they'd be better, but because I thought I'd have to kind of be independent, but it's actually a lot worse. I'm just kind of staying in the house a lot. I don't really have any friends or anything. I mean, my family come and visit a bit, but it's not, I don't know, it's kind of scary because I've just been kind of literally just in the flat by myself, which I always thought I'd like, but I don't actually like it.
Okay. So what are the kind of difficulties that you have been experiencing?
I mean, I'm a photographer, so I kind of, it's been stopping me a bit, my anxiety, from being able to get work, and because every time, you know, there's an opportunity that is kind of involving me having to interact with people, I just tend to just turn it down. So I was kind of making things hard in that respect, and just kind of friends-wise and everything, I just feel like I'm just kind of increasingly more alone. So it's kind of stopping me from making friends and, you know, relationships and stuff.
Okay, so you said that your difficulties are getting in the way of you doing certain things, so they're stopping you from taking up kind of certain types of work, and as a freelance photographer, I guess that can be kind of a problem. And they're also stopping you, or you feel like it's stunting you socially. You're not kind of able to make new friends and get to meet new people.
Yeah. It was kind of easier when I was at home because I was, obviously, I mean, my parents and stuff, that's fine, but, you know, I'd go to places with them, or I'd kind of have people there, but more and more I'm just finding myself just staying in a lot. I mean, I went 2 weeks ago for coffee with my friends, and the whole time I was just kind of wanting to go home again. So I just don't want that to happen. I don't want to lose everyone. So,
So you're kind of worried about where this is going to lead to?
yeah, yeah.
Okay. So you said that you first noticed the anxiety kicking in when about 5 or 6 years ago.
Yeah.
So you would have been about 19?
Yeah.
And what was happening around that time?
I guess I'd finished school about a year before that. And I mean, I've always been a bit shy at school, but it was never ever, like it didn't really affect things as much as, not at all as much as it has been doing the last few years, I guess. It just started when like my friends went to university, and I don't know, I felt like I was expected to kind of move out or just do something, and then it just kind of escalated from there. I'd just stop going to parties, or I'd just say no to invitations, or I don't know, I thought my job would help, because I mean, I love it. I really like doing photography, but I'm just kind of getting less and less work as it goes on. So, which is my fault. I keep saying no, but...
What kind of work is the most difficult for you in your job?
I guess when I have to kind of be working with other people. I don't like that. It's like when I'm trying to kind of do an event or something where there's a lot of people there, not just photographers, but actual, you know, if I'm like taking photos of people, that, I don't know, I just kind of find myself saying no. I mean, I want to do them, but just it's scary, so I just don't do it.
So I guess tell me a bit more about what happens then. So let's focus on maybe an invitation to do a job with, you know, it's going to involve photography with a group of people, and you're going to have social interaction. What kind of thoughts go through your head?
I mean, I get really hot and sweaty, and I feel like everyone's kind of looking at me and thinking that I'm just like really stupid, and I feel like they're all going to be staring and thinking I just can't do my job and I'm just an idiot, and I mean, they'll think that I just look like a weirdo, and I just kind of just try and get out of the situation or just focus on something else. So that's why I like doing shots where it's just me and the camera, because then I can just put all my attention on that instead of having to, you know, be with other people.
Okay, so it sounds like you have quite a lot of thoughts rushing through your head then at the point where you get that invitation and you think, people will look, people will stare, people will think I'm a weirdo.
Yeah.
So there's quite a lot about what you think other people will think.
Yeah.
And how does that make you feel?
Just makes me feel like an idiot. It makes me feel like I just shouldn't even bother trying to do it anymore. I should just go home, and I think I just don't want to be in that situation. I just feel like everyone else is fine and they're normal, and I'm just the freak who can't like do normal things. And
Okay.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
I'm feeling very stressed out lately, a lot of tension.
Can you tell me more about that?
I just feel like nothing I do is good enough. I work really hard, I try really hard, but I'm still having a really hard time.
So what I hear you saying is that you're feeling really stressed and kind of stretched out too thin.
I am stretched too thin. I'm trying so hard, but I can't live up to my dad's expectations. I really love him, but it doesn't feel right or what it should be like. My friends' parents support them.
And what do you wish things would be like?
I'd like to have more free time. I have lots of friends, and they get to relax and hang out after school, and I don't get to do any of those things. I like to do that or spend time with my boyfriend. My dad has always pushed sports. If it's not volleyball, it's another sport, and I just want to make him happy.
That sounds exhausting. So it sounds like you're feeling this contradiction of pleasing your dad and meeting his expectations, but you also want to enjoy yourself and be young. Is that right?
Yeah.
And so that must be really frightening, to be so confused about your dad's expectations, and I also imagine you feel pretty frustrated with him.
Yeah, I am frustrated with him. If I don't please him, it makes me feel like I'm not good enough.
What do you think your dad wants you to be like?
Well, he wants me to be in really good shape, make the best of grades, graduate with honors so I can get into a really great school, and I know he just wants the best for me, and I want to make him happy.
I can really hear you really love your dad, don't you?
Yeah, which is why not living up to his standards is so hard.
And so it's this feeling that only a part of you is acceptable. And that doesn't leave much room for you to be human, does it?
No, it's like he wants me to be perfect like those women in the magazines.
Yeah. And if his love for you is based on a picture, then what's the good of that?
You're right, it is no good. I can't ever be good enough for him. I can't ever live up to his expectations. And we have this college visit coming up. I feel like college is too far away. It's too far into the future. I feel like it's too much pressure, and I'm not even sure if that's where I want to go to school. I could visit at any point, but it's this weekend. My boyfriend was going to take me to a concert that all my friends are going to. I want to enjoy my life, not worry about the future. My dad said we had to go now, even though he knows about the concert this weekend. What should I do? It's not where I want to go anyway, but I can't tell my dad. I could never tell him that's not where I want to go. I want to be a kid. I want to enjoy my life. I just don't think it's fair. Why do I always have to live up to what he wants me to do? What should I do? Should I tell my dad I don't want to go?
So this is the conflict. It's really hard for me because I want to give you an answer, and I really wish that I could give you the answer you want. I really mean that.
But that's why I'm going to therapy. I thought you were supposed to tell me what to do.
Well, I don't mean to be evasive about this, but I want to know, what do you think you should do in this situation?
I don't know. Why can't I just be like a normal person and tell him I don't want to go? Why do I tell him things I really don't mean?
Mm-hmm. And so I catch that the real deep puzzle is you feel this, what should I do? Sometimes it's sad for me to notice how hard you are on yourself about yourself. And I really appreciate you sharing this with me.
Well, yeah, I'm hard on myself because I need to be, but I hate how I always have to live up to such high standards.
Mm-hmm. And so the thing that comes to mind is me asking, what do you wish I would say to you?
I wish you would tell me what to do. I feel like there's a part of me that really wants to please my dad, but in order to please him, I don't feel like I can be myself. There's just a part of me that feels lost and unsure of myself.
Mm-hmm. Yeah, I really hear that. And to me, at the same time, you don't sound too uncertain.
Oh, really?
Yeah, judging by the tone of your voice, it sounds like the thought of doing what your dad wants you to do is more uncomfortable than it is for you to actually tell him how you feel.
I just wish he would listen, that he wanted to know how I feel. He just wants me to be the perfect daughter, but he doesn't even know the real me.
And so you sort of feel this, I want my dad to like me for who I am.
Yeah, I'm not the straight A, size 0, perfect girl. And I can never be good enough. I can never be smart enough or skinny enough.
And what I think I'm hearing you say is that you'd like to feel accepted for your dad.
Yeah, that's what I want. How can I do that? Do you think I should say something to him?
Well, I feel like this is a really private thing that I couldn't answer for you, but I'll definitely try to help you come to your own answer.
It doesn't matter how much I want him to accept me. He wouldn't like the real me. I could never live up to his expectations. The thought of even saying anything is terrifying because I know he would be so disappointed. Would it even be worth it to say something to him?
I'm really not sure. It's an awfully risky thing to live, and you'd be taking a chance with your relationship with him, and you'd also be taking a chance with yourself.
Yeah, it really is risky. I'm never in control of anything. Sometimes I feel like the only thing I have control over is food.
That sounds really upsetting. I think what I'm hearing you say is that by controlling food is the only way that you feel that you can make a choice for yourself.
Even just talking about it right now is making me really tense because it's making me think of everything I ate today. Counting the calories is one of the only things that makes me feel better because it's something I can control.
So you're feeling anxious at the moment and like your only relief is in controlling what you eat.
I guess it's the only thing my dad can't control. That it's just mine. I don't think that's right. I wish I didn't have to be so hard on myself and I could eat like everybody else does.
So it's quite clear that the problem isn't just with your dad or your relationship with him, but it's also in you as well. And this question of how can I accept myself?
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Okay, your order sheet is in your chart. It's under the tab that's labeled Physician's Orders. You're going to check these orders against your paper MAR. There's 2 pages to your paper MAR, your routine medicines and your PRN medicines. So first check your patient's name, Sally Gunter, Sally Gunter. Okay, then check for the date of birth, 5/8/41, 5/8/41. The next thing you want to look at is allergies. Sally is allergic to penicillin. Your allergy is penicillin. And you want to go down and you want to verify every medicine that they have. So on the orders, it's potassium chloride, 40 milliequivalents, PO 3 times a day. Potassium chloride oral liquid, 40 milliequivalents, PO 3 times a day. K-Flex, 250 milligrams, PO every 6 hours. K-Flex, 250 milligrams, PO every 6 hours. Norvasc, 5 milligrams, PO twice a day. Norvasc, 5 milligrams, PO twice a day. Prilosec, 20 milligrams, PO daily. Prilosec, 20 milligrams, PO daily. When you're looking at your physician's order, make sure it has a date, a time, and a physician's signature. Sally Gunter also has a PRN order of clonidine, 0.1 milligram tablet every 6 hours, PRN for diastolic blood pressure greater than 90. Clonidine, 0.1 milligram tablet, PO every 6 hours, PRN for diastolic blood pressure greater than 90. Now all your routine meds and your PRN meds are checked against your physician's order sheet. The next thing you want to do is to look here. Number 1 is compare your order sheet to your MAR and then your initial once verified. So you would sign your initials that you verified these medicines.
Question 26. Now read the question.
Let's examine this. If I have a fearful thought that I could ultimately lose everything, then it's not going to move me forward. It's not going to help me think clearly. It's not going to help me, move forward and take the actions that I need to take. It can kind of limit me and make me feel like I don't want to do anything because I'm scared to do anything. But what I have found, and this is what I do all the time, is when I'm having a fearful thought, I know that I can't not think about something. Because the more you try to not think about something, the more you're just going to think about it. So you have to replace that thought. And what I replace that thought with is, how can I use this fearful thought or use this fearful event to make me a better person, a better nurse, and to learn from this experience? I'm happy to share this with you so that you can, hopefully learn from my mistakes. So what happened was, I realized that I made the mistake, and not only had I made the mistake once, I had actually done it the first time I administered the medication as well. So I thought about it, and I was like, okay, well, of course I have to do an incident report. With the mistake, I'm going to show her that I can, not only take care of the situation and have her trust me with her patients, but she can also see that I'm a very confident person and that this mistake won't happen again. So I went to her and I said, I told her the mistake, ultimately told her what happened, and, it was a mistake, and we examined it, and, she asked me a few questions, and it was an uncomfortable situation, but what I realized was that I came out of that as well as I possibly could have. Having the lack of confidence, you can replace that with, no matter what happens, I will build from this, and I will learn from this, and I will ultimately become a better person. So guys, it's all about replacing those fearful thoughts with thoughts that are going to serve you.
Question 27. Now read the question.
I was actually talking about culture-bound phenomena, and I had a professor of psychology say to me that there's no evidence that culture-bound or cultural illness exists. And I actually said to him, my response to him was that you're absolutely correct. And people were quite surprised when I said, you're absolutely correct in the world in which you live. So you actually can't necessarily blame someone if they've never actually been exposed to it before. So the important point is that if you actually don't have it in a framework that most people, and what I'm talking about is mainstream, can relate to, in that it's actually researched and it's written up in a scientific journal, then they're actually forced to relate to it, or at least open their mindset up to a different reality.
Question 28. Now read the question.
Hello, I'm Jan Machescu. I called this morning.
Yes, Mr. Machescu, your prescriptions are right here. They've been ready for an hour.
Good.
Now, take these pills 3 times a day. That's every 8 hours.
I usually take them at 7 in the morning, 3 in the afternoon, and 1 before I go to bed about 10 or 11 at night.
That's fine.
When do I take the other pills?
You can take these any time you feel a pain.
Well, it's almost lunchtime. Is it okay if I take one before lunch?
It's better if you wait until after lunch, after you've eaten.
Well, why is that?
The pills may upset your stomach if it's empty.
Oh, okay. I'll wait till after lunch. I'll take one about 1 o'clock this afternoon. Well, thanks very much for your help.
You're welcome.
Question 29. Now read the question.
Right, I'd like to tell you about all the patients on this ward, starting with bed 1. John Smith is a 45-year-old male who had a motorbike accident on his way home from work. He was admitted to the ED at 2300 hours on the 1st of August with a frontal lobe contusion.
Sorry, I don't know that word contusion. Could you please explain?
Sure, in this case it means a concussion.
Thank you.
He has breaks in his right arm and hand and has had surgery, including metal plates inserted into his arm. He also has deep grazes on his left knee and ankle and stitches in his right hip and shoulder.
Stitches in the right hip and shoulder?
Yes, that's right. All dressings have been changed this morning at 900 hours. He's on a self-administered morphine drip and he's also on an antibiotic drip. He has had injections to prevent blood clotting and his pain is quite manageable with the medication he's on.
Question 30. Now read the question.
I worked with this man called Graham. That wasn't his real name. He started to hear voices. He had strong paranoid beliefs that people were talking about him. He had to come into hospital, and the main way of actually helping overcome that loneliness and isolation as a result of his experiences was to really enter his world, to develop a shared model, a shared understanding of how these experiences shaped his beliefs and how that made him feel both emotionally and how he reacted behaviourally by avoiding a whole range of situations. It makes me feel really good actually, and it gives me a tremendous source of satisfaction that actually by relating to somebody, by understanding somebody, that you can actually empower them and help them recover. Without the benefits of professional help, Graham would still be stuck at home. He would still be experiencing rather distressing voices.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the monologue of a physician, giving a lecture on the different types of non-Hodgkin's lymphoma. You now have 90 seconds to read questions 31 to 36.
The two main categories of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is a large group of diseases with different symptoms, treatments, and outcomes. The appropriate name of the type of non-Hodgkin lymphoma may include a number of descriptive terms that can be difficult to understand. Lymphomas arise from lymphocytes, a type of white blood cell, which are of two types, T cells and B cells. Both help in killing infectious agents, however, in slightly different ways. Based on the type of lymphocyte turned into the cancer cell, the patients may have a T cell or a B cell lymphoma. B-cell non-Hodgkin lymphoma is the more common type. There are many different types of B-cell and T-cell lymphomas, each behaving in a different way. Pathologists performing biopsy of the tumor define the cancers in terms of grade. High-grade lymphoma cells look quite different from normal cells. They tend to grow aggressively. Low-grade lymphomas have cells that look much more similar to normal cells and multiply gradually. Intermediate-grade lymphomas fall somewhere in the middle. The behavior of these types is also described as indolent and aggressive. What the pathologist describes as a high-grade or intermediate-grade lymphoma usually grows fast in the body, so these two types are considered aggressive non-Hodgkin lymphoma. Surprisingly, aggressive non-Hodgkin lymphoma often responds better to treatment, and many people with aggressive non-Hodgkin lymphoma are cured if they are diagnosed early. The most common kind of aggressive lymphoma is diffuse large B-cell lymphoma. On the other hand, low-grade non-Hodgkin lymphoma grows gradually, and these lymphomas are therefore called indolent non-Hodgkin lymphoma. This group of non-Hodgkin lymphoma doesn't give rise to too many symptoms, but they are also long-standing and are less likely to be cured. The most common kind of indolent lymphoma is follicular lymphoma. At times, indolent lymphomas can transform into more aggressive. The majority of lymphomas are nodal lymphomas. That means they originate in the lymph nodes. However, it is possible for lymphomas to arise from anywhere else. When the lymphoma is mainly present in nodes, it is called nodal disease. Occasionally, most of the lymphoma may be in an organ that is not a part of the lymph system, such as the skin, the stomach, or the brain. In such condition, the lymphoma is referred to as extranodal. Therefore, nodal and extranodal refer to the primary site of the disease. A lymphoma can develop in a lymph node and then involve other parts at a later stage. However, in such a case, it is still considered a nodal lymphoma, but is said to have extranodal involvement. In follicular lymphoma, the cancer cells arrange themselves in spherical clusters called follicles. In diffuse non-Hodgkin lymphoma, the cells are spread around without any clustering. Most of the time, low-grade non-Hodgkin lymphoma looks follicular, and intermediate or high-grade non-Hodgkin lymphoma looks diffuse in biopsy. Non-Hodgkin lymphomas are also described as common or rarer based on the statistics of the new cases every year.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a physiotherapist called Chris Maloney giving a presentation about treating a high jumper with a knee injury. You now have 90 seconds to read questions 37 to 42.
Hello, I'm Chris Maloney, a physiotherapist specialising in sports injuries, and I'd like to present a case study to give you an idea of the sort of work I do. It features a very successful high jumper in her mid-20s who was referred to me with severe pain in her right knee, and that's the leg she takes off from when she jumps. What's more, when she'd stepped up her training in preparation for a big competition, the pain worsened, and she'd been forced to pull out of the event. After that, she'd taken several months off training to rest and get treatment from various therapists. To her dismay, however, not only did the pain continue, it actually got worse, meaning she was unable to do any strength training, let alone jump-specific work. By the time I saw her, she was on the verge of giving up, having lost virtually all belief in her ability. My initial assessment quickly confirmed patellar tendinitis in the affected knee, accompanied by some swelling and significant tenderness over the lower part of the kneecap. This wasn't difficult to diagnose. I also noted that she was slightly overweight for her height and had rather flat feet, but that's not so unusual in high jumpers. Further assessment revealed that the gluteal muscles connecting the hips and thighs were considerably less sturdy than you'd expect in an athlete of this calibre, and both the lateral retinaculum connecting the patella to the femur and the iliotibial band, the ligament running down the outside of the thigh, were tight and tender. As a first stage, I was keen to show I could help by relieving some of the pain, so I worked at loosening her lateral retinaculum to see how much of the tendon pain was due to inflammation and how much came from restriction of normal patellar movement. This manipulation and massage instantly cleared the pain she'd felt while doing a single-leg dip exercise, where you stand on one leg and bend the knee. This indicated that her tendon pain was most likely due to patellofemoral joint dysfunction, caused by muscle imbalance and poor biomechanics, and not by an active inflammatory process or partial tear in her patellar tendon. So an MRI scan wasn't needed. The treatment continued along similar lines for some weeks, with loosening of the lateral retinaculum and deep tissue massage of the iliotibial band and other muscles. One option at this point was something called taping. This is a way of reducing pain so that athletes can continue with strength exercises. But it seemed clear from early on that we shouldn't put taping on this patient's patella and tendon until she started jumping again. She was getting pain relief and progress simply from the manual techniques, and taping might have led to problems later on. Athletes often become dependent on tape and other accessories. In other words, instead of aiming for 100% muscle strength and joint position control, they settle for 80% plus artificial support. The patient also had a specially designed program of gym activities. Although she needed to restore power to those muscles affected by inflammation and tenderness, the priority was to get her posture and alignment right. She started by doing double leg squats with her back to a wall in front of a mirror so that she could see whether her feet were arched and if her knees were over her feet. She also did squats while squeezing a ball between her knees. There was light leg press work, followed by single leg stance work, first static, then on wobble boards, and with elastic resistance. She progressed to moving on and off steps, sometimes holding weights, all the time paying close attention to positioning and muscle and joint alignment. The next stage was to liaise with the patient's coach. She began running, jogging for stamina, and then sprint sessions. Work on power was stepped up gradually and included some weightlifting. After some analysis, we also decided to modify her run-up to the high jump bar. By beginning from a wider position and running in with much less of a curve, there was much less of an impact on the ankle, knees and hip, especially in her right jumping leg. Interestingly, the patient reported that remodelling the run-up felt fresh and motivating and helped to reinforce the sense she had of being a reborn athlete. Once the rehabilitation process was complete, she was able to compete without pain and free of any reliance on taping or knee strapping. So, before I go on...
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.